I think we are now able to answer questions. Darius?
Yep.
Yep.
I'll start with the LHON presentation by Claudia. There was no specific question, but I wanted to ask Claudia. My understanding is that a lot of children actually are carriers for the mutation, but not all of them ever develop LHON. Can you explain that, or is there any thought, why that is? And in turn, if one understood that mechanism, could that be used as a therapy or as a prevention?
Yes, this is actually a big issue, and it's not known who develops LON or who converts or not. And to this date, there are no predictive factors, because if there was one, we would like to treat prophylactically, and which would make more sense than treat when already tissue is destroyed. But also in adults, I think only 40% convert to LON, and all the rest are asymptomatic carriers. So we have a follow-up of huge families of asymptomatic carriers, and as far as I know, since we follow them, none of them converted to the disease, so they only come by chance.
Thank you.
Claudia, I also have a question for you. How do you discover them? And if you discover them, how quick can you treat them? And for how long you have to treat them?
So the discovery is often, usually most patients are suspected optic neuritis in the beginning, and I would say 80% get intravenous corticosteroid, and MS is excluded and all the screening is done. And then when they don't become better and the second eye gets involved, usually the diagnosis LON is established. So it's the same thing still, because also OCT and VEP don't really help to distinguish. It's the same in adults as in children, and in children, we further have the issue that the onset can be insidious or only one eye involved, as I said before. So we only have to remember that this can happen in children. That's the one thing. What was your second question? Sorry.
Second question, how long do you have to treat?
To treat? We treat them for 24 months until a plateau is reached. And if we have the impression that they're still improving, we continue. So the children, we saw, interestingly, that it's in the third year when we saw the most improvement. But it's a very small group only, and yeah, certainly we need more data and more patients.
Yeah.
Yes.
Well, luckily it's a small group, because you never wish a disease like this to young patients. Yes. Or any patient. But thank you for your excellent presentation.
You're welcome.
We learned a lot, but we still have to work
yes.
on this issue. And good luck with your meeting in Munich.
Thank you.
Then I would like to go to Anne Hellstrom. Darius, were there questions from the audience?
Yeah, I don't think there was a specific question I could see in the from the audience, but I had two questions for Anne. First of all, fantastic.
Yes, well.
Yeah, amazing work. I mean, it's just really beautiful, absolutely beautiful. One question was, you mentioned you mentioned omega-3 and omega-6 supplementation, and that it can work. In cancer, they use omega-3 as an anti-angiogenesis agent and as an anti-inflammatory agent. It affects the prostaglandin pathway in a way that it's anti-inflammatory. Yeah. Is that how you think it works in ROP, anti-angiogenesis and anti-inflammation? Is there an inflammatory process in ROP?
Yeah, that's a very, very good question, and it is actually a very up-to-date question regarding pathogenetic mechanisms and ROP. And in fact, we have seen that there is a close association between DHA, omega-3, and inflammatory markers in the preterm infants. So I would think that one way of its action is actually through down-regulating inflammatory responses. I don't think that DHA is anti-angiogenetic itself, but it might promote other cells to be anti-angiogenetic. Regarding omega-6, we know that is pro-inflammatory in adults. However, in growing fetus, it is extremely important for all membranes. So we have seen that a certain level of arachidonic acid is actually required for DHA to have its actions. So I think it's a bit different in adults and in these extremely preterm infants.
It may be the angiogenesis effect is described in oncology, but it may be that it is cancer specific, especially prostate disease and breast disease. The second question I had was about VEGF. I mean, you must know it if anyone knows it. Are there systemic long-term ill effects of giving a baby VEGF?
Well, I really hoped I could answer that question. The problem is that there are actually, at the moment, there are no prospective randomized trials looking at the baby's systemic, like the effects on the organ systems for long term. There was one publication from the Rainbow trial, which was the ground for Lucentis to be approved, but that was at 2 years of age and not looking at all organ systems and not looking at MRI of the brain, for instance. But what we do know is that this agent, we know that Lucentis is found in the circulation for approximately a month, maybe a little bit more, and that it suppresses the circulating VEGF levels. So theoretically, it could have an impact, but as of today, we don't have that information.
But you can detect VEGF in the bloodstream. It is not just theoretical. There is actual presence of VEGF in the bloodstream detected.
Yeah. There is presence, but it also depends on in what how you measure it in serum or in plasma, and of course it's more in serum. But we know that the levels are suppressed. The VEGF levels are suppressed for approximately 4 to 6 weeks after Lucentis, and a little bit longer for Avastin, and maybe even longer for Eylea.
Thank you.
Thank you. I think we have to continue, otherwise we cannot answer all the questions. Darius, you got a lot of
I got a lot of questions.
And I was also, maybe you can pick up some of them, because most of them were on how do you apply the timolol. Yeah.
So the question that always comes up is, I say timolol drops, and people say, what about ointment or gel? And it's of course the perfect question to ask. The fact of the matter is timolol maleate is like olive oil. It is, if you next time take a timolol bottle and just put a little bit on your finger, it is like sun cream or sun oil. It goes in straight away. It's very lipophilic. The maleate is a long carbon chain, and it makes it very, very lipophilic. So actually even though they're called drops, they're actually very lipophilic, and they have the effects of gel and ointment, exactly as one would think. So that was one question, a set of questions. Another one was whether you could inject it directly into the hemangioma. I would not at all do that, because of course the hemangioma is vascular. If you inject it, you can get bleeding, and number two is you now inject a high dose bolus into a vascular component, and it can spread, at least theoretically, into the venous circulation, and then from there into the systemic circulation, and it may cause sudden cardiac or respiratory effects. So I would not do that, and there's no need for it. If you put the drops into the skin, it is absorbed very quickly, and you can detect it in the bloodstream.
Okay.
The third question was
Yeah, we only have one more minute left for the questions. Maybe you can answer other questions by email. And I would like to continue then with Ed. Ed, you have the last questions. One of the questions is the Dexacu or the Dextenza. People are asking, will that not fall out of the punctum?
Right. No, that's a good question. It goes in as a very thin a log shape, but as soon as it gets wet, it swells up like a sponge, and then it won't come out. So if you get it wet before you get it in, you'll have to discard it and get another one. So it really swells up, and we haven't seen any of them dislodge.
Excellent. We are very happy that the Silsoft lens is starting to get back on the market, because we have lots and lots of parents complaining that the alternatives are not really as good as the Silsoft lens they were used to, and so they are back on the market in the United States.
Yes.
And so in a couple of months we should receive them in other parts of the world.
I hope so. I mean, they're coming in a blister pack rather than a bottle these days, but we've been receiving the new packaging already.
And same fit, same substance,
same lens. Excellent. They just had problems with the packaging.
Excellent. And another thing I noticed that are used in some surgeries still using a traction suture through the superior rectus muscle.
Yeah, I still do. I know that's an old school thing, but the Bell's phenomenon really affects things when the child gets light under general anesthesia. I still find that it's useful to have that forosilk on a taper needle under the superior rectus muscle to help control the glow. So I still use it.
Thank you. And interesting that you have getting a lot of experience with artisan aphakic IOLs in a short time, but that's compassionate use in the United States. And always for other listeners, never forget to make a peripheral iridectomy in these cases. At least that was how I was taught.
And very quickly, there was a question about intracameral steroid, and I do commonly use dexamethasone, preservative-free, 0.1 cc of the 4 milligram per cc of dexamethasone right with the antibiotic as the two separate injections right at the end of the surgery. That helps.
Okay, well, thank you very much, all presenters. These 2 hours went over very quickly. Thank you very much on behalf of the SOE and also from the European Paediatric Ophthalmology Society and the International Paediatric Ophthalmology and Strabismus Council. Thank you very much. And for people who would like to see it back, it's on the website of SOE webinars. Thank you very much and stay safe.
Bye.